All righty then.
I love it. We're going to do accents.
We are. We're going to teach this chapter with British accents.
All right. So keep in mind that this is, again, a quick overview. It's not meant to replace your reading, but...
Or your class time. You need to come to class. But this is just a little quick overview that's going to help you to understand Chapter 23.
Okay. And where do we want them to focus?
Okay. So Chapter 23 is going to talk about angina, MI, and CVA, which you should be learning currently in 221, at least the angina and myocardial infarction. So if you look at the objectives that we've highlighted there, number 4 and number 6, 4 talks about the drug classes. And as we mentioned before, you want to look at those little prototype drugs, drugs at a glance, look at the representative drug, its classification, how it works, mechanism of action, side effects, and then anything bolded that could be a very adverse effect. And then the 6th objective, which is the nursing process. So we always talk about that nursing process focus.
And are there any meds they don't need to focus on?
Oh, yes. Well, I'm glad you mentioned that. The medications there that we've got.
We don't think you need to focus in on these glycoprotein 2B3A inhibitors. We won't be giving that. That's for critical care. Also, we've talked about thrombolytics from Chapter 26. So you'll remember Retaplase or those medications that end with A's or typically enzyme. Yes. So those are medications that are overlap, but you won't be administering thrombolytics. However, maybe just lightly preview the health teaching that goes with a client who's recently received it over the last few weeks. All right.
All righty. So moving right along.
So you can see here we've got some key terms that are bolded for you. If you are using the online resources, you can actually click on the mouse and that will take you to a link. This is the Canadian Cardiovascular Society. So if you want to learn more, you can click on that. The terms we want you to be familiar are all highlighted in blue: angina, atherosclerosis. I'm going to trip on my words, but you can see them and read them for yourself in the page numbers that they refer to. We want you to understand coronary artery disease, myocardial infarction, plaque atherosclerosis. So please spend some time getting familiar with that. But this is a great visualization of what's happening. You can see that there's plaque building up inside the artery, and it's where the blood would normally pass through, that little lumen. It becomes smaller and smaller, unfortunately, to the point where it's completely or significantly occluded. Thank you.
And you know, that really reminds me of with the asthmatic, with the mucus production and how the airways slowly diminish in size. It's the same idea with the person with asthma. They can't get the air out. In this case, we can't get the blood through to oxygenate those vital organs.
Absolutely. Spend some time looking at angina. Right now, we want to stress that angina pain is usually precipitated by physical activity. Maybe it's shoveling snow or an emotional argument. So be listening to your clients when they're complaining of any chest discomfort. They might not use the word pain, depending on their culture. They might just use the word heaviness, shortness of breath, or pressure. So be listening for those types of words. There are 3 types of angina. So if you want to come to class knowing those, we've got stable and unstable, and then variant angina. Also, up here, we've got a little highlighted paragraph for you there. So we're going to keep moving forward. You can read that on your own.
Just note, too, there that it said that angina pain usually subsides if they sit down. So they're out there shoveling the snow. When you're asking them about their pain, what were they doing when they had their pain? Oh, I was out shoveling the snow. Okay. And when it disappeared, what did you do? Well, I sat down and then it slowly went away. So that's pretty typical of angina. With an MI, the pain's not going to stop.
And sometimes it's just taking stairs or walking city blocks. People will say, oh, I get winded or short of breath or chest pressure, or I feel like I'm burning or I'm breathing in the cold. So people describe it in a number of different ways. So, but yes, it definitely, one of the first things that we do as nurses is stop the activity that they were doing. Definitely pay attention to some farm facts over here. Clearly you can see how relevant cardiovascular disease is in our community and, well, globally as well. Mm-hmm. Some goals of pharmacotherapy for angina. So most of the medications we're going to give are intended to reduce the cardiac workload or reduce the demands on the heart. How they do that is either by slowing the rate, dilating the arteries and the vessels in order to provide more oxygen, and then causing the heart to contract less forcefully, maybe dilating the arteries. So we'll talk about it in class, but the arteries, that's the tubes that or take oxygenated blood away from the heart. If these are small, it would be very difficult to pump through. So we dilate those, and it makes it easier for the heart to pump oxygenated blood through the arterioles. Special considerations when you do read and learn about nitroglycerin, there is some health teaching. Clearly, you want to practice maybe some of these generic but yet useful health teaching considerations over here, and recognizing when to call 911.
And how the patient should take their nitro is so important for them to understand. If they're not taking it correctly, then it's not going to help them. So this particular box is of extreme importance. So make sure that you know this like the back of your hand.
Also, nitro expires like many medications. So there will be times where clients go significant periods of time in their life where they have not required nitro spray. But as you can imagine, as the arteries in the as the plaque builds up over time, the need for dilated arteries would definitely be there. Or maybe their angina is coming more frequently now. Used to come once a month, now it comes once a week. So that would be cause for concern for us as nurses. All right, just talks about tolerance.
Yeah, what I was going to say was in the clinical setting, what you'll notice on the MAR is that it'll talk about taking the patch off at night. So maybe you're applying the patch at 9 in the morning, but then it'll say at 9 o'clock at night you need to take it off. And that's to decrease the incidence of tolerance, because the body will sort of build up a tolerance to the medication.
And spend some time looking at these prototype drugs. Nitroglycerin is a very common medication, so we're not going to be giving it IV. So you don't need to read or learn anything about IV administration of nitro, but what I think you need to appreciate is nitro spray, or the sublingual tablets, or the paste that you might apply topically.
Right, or the patch.
Yes.
So back in our day, it was a paste, James.
Yes.
They don't do that anymore.
They don't?
We used to have to measure it out like toothpaste on toothpaste.
1
Remember
inch,
that?
2 inches, yes.
With your gloves on, because you'd have a splitting headache.
And also definitely wear gloves when you're applying patches or paste or whatnot. And nitroglycerin needs to be protected from the light. Light breaks it down. But spend some time reading the nursing process. We expect you to know this very well for nitroglycerin. And
notice too on the bottom of that prototype drug square where it talks about concurrent use with Viagra can cause life-threatening hypotension. This is something that you need to know. You need to be teaching your patients so that they're not using these medications at the same time.
And I'm just realizing some of my pins are not showing up, so I'm going to take a peek. Oh, there they are. Yay. So if you are following along, you're going to notice that we have pins, and we're trying to encourage you to pay attention.
And click on those pins and look to see what kind of hints they're giving.
Yeah. So if you're notice beta blockers commonly end with LOL. So if you are using that, some of these pins don't have anything in them, but they are read and understand nitro spray assessment and health teaching, obviously. And then maybe there's something here that Professor Smallhorn just mentioned. We just use the word fatal. You would need to click on that and pay attention. All right.
So now we're moving along through the nursing process focus for clients receiving nitro. Of course, as usual, that's a huge focus for our test. Anytime there's teaching to be done, we'll be asking you questions about that.
Yeah, so spend some time over here where taking one tablet every 5 minutes. This is always confusing for clients, especially if they've never had a prescription for nitro before. Watch the video and listen to it very carefully, and maybe imagine if you were the client, how difficult would it be to follow these instructions. So the more knowledgeable you are, the safer or the more help you can offer your clients.
And the thing too, I think I've mentioned in class before, and so is Professor Mears, that if the patient understands the medication and how it's working, they will be compliant and they will take it. And we're saying that headache is a common side effect. I remember when I was a brand new grad and my patient was struggling with angina. And I said, well, do you use your nitroglycerin? And they said, well, no, there's something wrong with my nitro. It gives me a splitting headache. And I said, oh, but that's an expected side effect. That means it's working. And the patient said, well, nobody told me, so I just didn't take it. So it's important that they understand these things are going to happen. They are going to get a headache. They need to know that. But you need to let them know that that's an indication that the medication is working. It's dilating those vessels.
And the big thing is their chest discomfort, heaviness, or pressure going away? So you're going to take them through a pain assessment whenever you do have chest discomfort, and that's your PQRSTU assessment. You want to do that very thoroughly, and you're going to do that quite frequently if there is any history of cardiac disorders or history of cardiovascular disease. If they suddenly complain of chest discomfort, you want to take them through a thorough assessment, and hopefully if they do have a prescription for nitro, they're using it properly and it's not expired.
Right.
Beta blockers, common medication that you'll see with clients that have a history of cardiovascular disease is a beta blocker because it slows the heart rate down, slows the conduction system. Hopefully you have an appreciation for where the conduction system starts, but again, that stems back to your biology. So think about the electrical pathways through the heart. Where did that signal initiate? How did it travel through the heart, etc. But beta blockers slow that node from firing off a signal.
Just remember, it's blocking the sympathetic nervous system. So when you're running away from the tiger and your heart's just pounding, if we block that effect, then your heart rate's going to slow and your blood pressure is going to drop. And it's going to decrease the workload on the heart.
And we've got, again, an emphasis on these bullets. Educate your clients to change their position slowly because, again, you've slowed down their heart rate and lowered their blood pressure. Changing positions can cause orthostatic hypotension. Be careful. Avoid over-the-counter medications with herbal products. Without discussing it with your healthcare provider. Do not discontinue this medication abruptly. That is a very important one. In fact, I think we'll just drop a pin there.
Yeah, because when you think about it, if you've decreased the workload on the heart, but then you stop that medication, what's going to happen is suddenly there's going to be an increase in the workload and
your heart's not ready for it.
It's not, and you're going to go right back to being in the same spot with an MI or whatever.
Yes, and if the over here is key.
This is huge.
If you're filling out your drug templates, I hope you've been following along and filling those out. If your pulse falls, and it says below 50 beats per minute, but in fact, I'd be concerned, even though we like pulse. It says right here, this may be 60 beats per minute in certain agencies. I like to err on the side of caution and get a physician to write a parameter. When do you want us to call you? When do you want us to hold this medication? But medications that lower the heart rate, the normal heart rate or pulse is 60 beats to 100 beats per minute. If it falls below normal, I just want to double check that I'm allowed to give it. So I might have to assess the apical pulse. And if it's below 60 beats per minute and they're symptomatic, then I would definitely be holding this medication. Do not give it. Double check with the doctor. Most
of the time on the MAR, it'll give you a little star with to hold it, but it doesn't always. And last semester I was in clinical with some students, and the nurse actually had a patient with a heart rate of 48, and she went ahead and gave this medication. It was a beta blocker. And so I said to her, "Oh no, you shouldn't have given that. You should have held it." And she said, "Well, no, there's no indication on the MAR that I need to hold it." And I said, "Okay, but is a pulse of 48 normal?"
And that's where I really want to say this is fundamental nursing knowledge. That nurse should have known the normal reference range for pulse, and some sort of instinct or critical thinking should have gone into play where even though it doesn't say it on the MAR, it says it in the drug guidebook. It says it in the pharmacotherapy book that you're reading and watching right now. So you need to know that if vital signs are outside of their norm, you need to think twice and ask yourself, is this consistent with their baseline? What could happen when in that situation, the pulse was 48? Can you imagine? That would significantly drop it to maybe in the 30s. That is very dangerous and life-threatening.
And somebody's not always going to be there over your shoulder to say, "Hey, you need to not give that," right? This is where you have to use your own judgment, your own critical thinking skills and say, "You know what, this isn't normal. I need to think about this before I do anything more."
Yeah, it's a lot of responsibility. Now, and again, it says, if below 50 beats per minute, but it might be 60 beats in some agencies. I'd rather be safe than sorry.
I think the majority are 60.
Yeah.
I really do. I haven't seen many that hold it at 50.
No one's going to fault you for double checking at 60,
That's right.
unless the order says it's okay to give it if the pulse is 52
But even
or 54.
then, if it did say hold at 50, if the pulse was consistently 52 or 54, I'd definitely be making a note of that.
Oh, and monitoring the client carefully.
And maybe bringing it to the attention of the doctor and saying, this pulse has been consistently low.
Yeah. Another medication that are commonly used to treat angina and cardiovascular disease is a calcium channel blocker, and it works. It's nice in the fact that it works directly on the cardiac arteries, coronary arteries. Sorry. And so what it does is it dilates the arterioles. And we won't get into all the cellular biology of what it does. But again, you're going to notice a common theme. Take blood pressure and pulse before administering. There will be times when you're going to teach clients to take their own blood pressure or pulse, either with a machine or manually. And you're going to advise them to get information from the healthcare physician about whether or not they should be holding it, at what point should they hold it, etc. Anything?
Yeah, that's good.
Yep. So calcium channel blockers. We on the video, I think we mentioned something, or the earlier video, we mentioned Zempines and To the Mill.
To the Mill.
And those are medications you want to avoid taking grapefruit with. Those are all calcium channel blockers. So if you haven't put a pin there or starred that, that's pretty important.
Anytime there's a drug-drug or a food-drug interaction, we will for sure be asking questions about it on the test.
Yes.
It's really important for patient teaching.
Now, you're going to notice these changes in blood lab tests. I think these are important to note, but at the same time, this is not theory, this is pharmacology, so we're not really going to be testing on that. So this would be more relevant to your clinical and to your theory course. Good to know and understand. You can click on this, and that's going to take you, actually, I'm going to click on it. Everything that you wanted to know about after a heart attack, if you've had a heart attack or a myocardial infarction, you can click on any one of these tabs, and these are questions clients might ask you, and you might want to be familiar with the answers that you'll get from your fundamentals textbook, your pharmacology textbook, but also maybe experienced nurses, etc. Like we said, we're not going to expect you to spend a lot of time on Retaplace. Yep. So moving forward, and we're almost done.
Yay!
Yep. We do want you to understand cerebral vascular accidents and that there are two kinds. So spend some time noticing the difference. Also spend some time understanding the signs and symptoms to watch for. So hopefully you've clued in that these are all signs and symptoms of a stroke. Now, whether that stroke is hemorrhagic or ischemic, that needs to be determined, and we'll talk about that in class. But spend some time reading the chapter summary and the review, and completing your pre-class questions.
Very good.
All right. Any questions we should ask them?
What
are you going to do before you give a beta blocker?
What are you going to do before you give a calcium channel blocker?
Yeah. What are you going to do before you give nitroglycerin, etc.? But all right. See you in class.
Bye.